Good morning, Dr. Mashitah, Dr. Fairuz, and my colleagues. Today I'll be talking on COVID-19 management. Can see my slides?
Yes.
Okay, doctor. So for my presentation, I'll briefly touch on phases of COVID-19 disease, case definition, categories of COVID illness, X-ray findings, risk factor for severe COVID illness, as well as the treatment. So first we'll start off with phases of COVID-19 disease. I've attached a graph here where you can see on the x-axis represents the timeline of the disease, and on the y-axis it represents the disease severity. So COVID-19 comes in two phases. First is the antiviral response, followed by the host immune inflammatory response. Usually, patient will came in with mild symptoms like fever, headache, diarrhea, and all. During this time is when they are having viral replication phase, and the virus can be detected by PCR tests. And some patients will move on to pulmonary phase, where they have pulmonary symptoms like shortness of breath, cough, and even hypoxic event. So during this time, the X-ray, we can see opacity on the lungs, and if you do a CT scan, they will have ground glass opacities as well. And certain numbers of the patient will go in, can have ARDS-like picture, or the respiratory distress symptoms, cardiac failure, and all. And during this time, basically the body. So that time we will have the cytokine storm lah. So if you notice this graph, there's actually a biphasic phase of fluctuating kind of response, which means that the patients may come in with the symptoms, which eventually gets well or better before the condition worsen. Okay. So case definition, just now, JEYA has already presented, so I'll just briefly go through the slides. So as for a confirmed case, we need a positive PCR test to indicate that the person actually has the illness. Whereas for probable case definition, the person can have a positive screening test like RTK, and they also have to fulfill clinical and epidemiology criteria, which means that they have to have contact with a confirmed case of COVID-19 patient, or have a history of traveling to foreign country, or attend an event with a known COVID-19 cluster. As for clinical criteria, they need to...
Chaying,
Yes.
you don't need to go into details of this slide, because even if you see your source to CPRC Hospital Services, October 2020. So basically this slide is almost a year old lah. So even recently pun a lot of this criteria kita we because at this time COVID is still fairly contained. So that's why you have all these criteria to select patient yang nak buat RTK or PCR. But with the last outbreak kan, pretty much everyone with flu-like illnesses kita terus buat RTK kan, because the contact history to become a bit irrelevant because COVID is in the community. Because at the time of this slide this guideline came out, was published, at the time the COVID wasn't in the community yet. You still need to have history of contact and everything. But nowadays history of contact too is not as relevant, because pretty much anyone can have COVID kan. Pretty much everywhere you got COVID. You got COVID walking around dekat Aman Jaya dan sebagainya. So it's good to know, but you don't be too fixed with this criteria lah, because this is a year-old criteria already. So basically nowadays anyone with any URTI symptoms or respiratory punya symptoms, it's COVID until proven otherwise lah. Okay? So carry on.
Okay, doctor. So okay, I just move on with the category of COVID-19 illness. So we can see patients mainly in 5 major category in terms of the disease progress. So first one would be asymptomatic patients. Second group is those with symptomatic but then no pneumonia. Third one is symptomatic pneumonia. So the first 3 group we consider as a relatively mild disease is the one with symptomatic pneumonia, which required supplemental oxygen. And the last one is those who are critically ill with multi-organ involvement.
So, how do you differentiate between category 2 and 3?
We can do a chest X-ray because
You have to do chest X-ray lah to
we have to
differentiate
do
between
chest X-ray.
Cat 2 and 3. So basically, this is for you lah later. Anyone that you label as COVID Cat 2, you need to do chest X-ray because symptoms here might refer to myalgia, a bit of headache, a bit of sore throat. Patient may not have shortness of breath, cough, dan sebagainya. And the only way to differentiate between whether this is a category 2 or category 3 is by doing chest X-ray because I think you guys also have a lot of experience kan. COVID Cat 2 nampak very well tapi X-ray turns out to be quite bad. So all category 2 and above, all category 2 lah. Basically patient needs to have X-ray because mungkin quietly dia category 3. Okay. Carry on.
Okay. So there are some risk factors which indicate for severe COVID-19 disease. These are the risk factors and signs that we have to watch out when we see the patient. So usually patients who are older, age more than 50 years old, and those who are with multiple comorbids. For example, hypertension, cardiovascular disease, chronic kidney disease, DM, pulmonary disease, history of transplantation or immunosuppressed, and obese patient. These are all the patients that we have to put extra caution. And clinically, if we see them who are having exertional dyspnea, SpO2 less than 95 under room air, having high respirate rate more than 25, and also persistent worsening cough or persistent or new onset fever, we have to watch out as well. As for the lab markers, they will have highly raised inflammatory markers like CRP, ferritin, and also persistent low ALC less than 1. In terms of radiological finding, patients who are having multilobular involvement and also rapidly worsening chest X-ray, they tend to have a poor prognosis as well lah. And this critical phase tends to happen between day 5 to day 10 of the illness.
Okay. This slide, just go back to the previous slide. This slide is important because it helps you to predict which patient may deteriorate, which patient that you need to keep longer. Because our guidelines change kan. Because I think if of course you guys tak biasa jaga PKRC. In PKRC, patient category 2, 1 and 2 yang admitted to PKRC usually discharged after day 10 because if patient condition remains well over a period of 10 days, usually they think patient, it's assumed that patient is gonna be well lah. Tapi sometimes some patient, those with risk factor or even walaupun tak ada clinical signs tapi the laboratories punya markers is worrying kan, macam CRP is very high apa semua, you keep the patient longer because one of the problem with COVID, patient looks much better than how they actually are kan, your happy hypoxia dan sebagainya kan. So sometimes patient COVID ni looks well tapi biochemically it's bad lah. So this will help you to decide which patient that you want to keep longer than 10 days, or even if the same patient is dah 14 days pun in hospital tapi you see the biochemical markers is not improving apa semua, this is the sort of patient that you need to keep longer, because there's macam the previous slide where you show there's 3 peaks kan, there's 2 peaks of time diorang nak worsen kan. Sometimes they got better, worse, then got better, then there's a potential peak where they got worse again after they discharged or after they got better. So these are the things that help you to predict. Carry on.
Okay. So, warning signs in COVID-19, I've explained just now. I just want to highlight there's a test that last time we used to carry out in our COVID bay and now the ED bay, 1 minute stand test. It's basically a test used to detect whether this patient having exertional desaturation. So we ask the patient to repeatedly sit and stand with hands outstretched as many times as possible in 1 minute. So if they having a fall of more than 3% or more on pulse oximetry reading, after the exercise, we will consider this is a positive test. So which means that the patient has less exercise capacity in their lungs. So this kind of
patient
patient
can't perform 1 minute test.
Yeah, we need to have close monitoring lah.
Which patient that you shouldn't perform 1 minute test on?
Patients that is ADL independent, able to sit and stand, and if patient having SpO2 of more than 95 under room air, and we essentially don't do this test on pregnant women lah.
Okay, so there are not all patient lah you buat this 1 minute test First of all, patient needs to be able to sit and stand lah. And don't patient on wheelchair you suruh buat sit and stand kan, kesian patient. So, and if patient already on oxygen, don't bother lah, because it meant that patient already hypoxic. So it's meant for patient who looks well on air buat, bukan for patient yang on oxygen ke apa ke So jangan salah faham pula Okay, carry on.
Okay, so just now Dr. Fairuz has mentioned about happy hypoxia. I just want to highlight this is actually one of the principal reasons for COVID mortality that tends to occur in 30% of the patients who require hospitalization. It is also known as silent hypoxemia, which defined by there's already a marked arterial hypoxemia with no corresponding symptom of the respiratory distress. So that's why we can see patient looks well and fine on the outside, but they are actually already hypoxic in the body system. So the primary cause could be there's a widespread of clotting in the complex network of small blood vessels in the lungs. So they doesn't have any significant respiratory difficulties even at low oxygen desaturation. This is why we encourage patients to monitor their saturation at home with the pulse oximeter.
Do you?
So,
do you actually tell patient bila tengok COVID patient, pakcik balik rumah beli pulse oximeter and check? You should lah. What I'm trying to say is you should give specific instruction to patient who you want to discharge for HSO kan, patient COVID, to go. And nowadays Maiden also sell, Tesco also sell kan. So just go, and if they can afford it, I mean it's only $20 nowadays. So to buy this pulse oximeter and monitor their oxygen saturation and so at home, and to come immediately if they have any desaturation, if the level fall below certain levels and sebagainya. You need to be specific with your instruction. You need to tell your patient, because this is one of the reasons why banyak BID masa COVID tengah PKP kan, banyak COVID BID because of this happy hypoxia lah. Okay, so bila you tengok patient COVID dekat COVID bay ke apa yang you want to discharge with HSO, be specific about your advice, and this is one of the specific advice that you need to tell patient. Buy a pulse oximeter, monitor yourself at home, and if there's any drop, to come immediately. Okay.
So here I've attached some typical chest X-ray findings of a COVID patient. So you can see the white arrow. There's some ground glass opacity, mainly is in the mid and lower zone. but then the lung marking here is still preserved. And if you look at the black arrow, it's actually there's some linear opacity which can see over the peripheries of the mid zone left side. Okay. And this one, I just want to point out the consolidation bilaterally lah. In this chest X-ray, the lung markings is already lost, especially over the mid and lower zone.
So just for you guys to be aware lah, sometimes COVID punya X-ray, you see this kind of X-ray, when what you notice, patient still not intubated kan. For you know, zaman before this kan, patient with this kind of X-ray usually most likely require some form of airway punya ni lah, most likely dah intubated, really bad tachypnea. And sometimes with patient COVID, you can have this kind of X-ray, tapi patient, saya okay doktor, saya nak balik, kan? So just be aware lah. Okay, carry on.
Okay. So here it shows that it like a series of X-ray. So over the most left side, it's actually
all same patient lah.
Yeah, same patient. Like this one is before admission. Okay, like few months before admission, patient actually have a normal X-ray, and then the middle one is when patient started to develop COVID pneumonia. You can see the ground glass opacities over the periphery of both lungs, especially over the mid and lower zone. At this time, the lung marking still preserved and linear opacity over the left mid zone. And eventually, this patient, a few days after admission, it progressed into the severe pneumonia. This time, patient is intubated with all the lines off. You can see there's extension of the ground glass changes. It goes beyond the mid and lower zone already.
Why the different arrows? Is it pointing to different things ke?
The most right one, the white arrows is
No, I'm just curious. Yeah, just you know, why the different arrows? Trying to show different things, you know.
Okay, the middle one, the black arrow is linear opacity.
Okay.
And then white arrows is a ground glass opacities.
Okay.
And then the most right one, the white arrow pointing towards the extension of the ground glass appearance. And then the outline arrow, there's a dense consolidation behind the heart.
Okay, good. Carry on, no worries.
Okay, so one of the most worrying thing about COVID-19 is patient might get into ARDS. So based on the Berlin 2012 ARDS diagnostic criteria, it is characterized by first acute hypoxic respi failure, and the patient have this presentation within 1 week of worsening respi symptom. And on the chest X-ray and CT or ultrasound, they will have bilateral air space disease that is not fully explained by effusion, lobar, or lung collapse or nodules. And the last one, cardiac failure, is not the primary cause of acute hypoxic respi failure. So this thing, it develops in around 42% of the patient present with COVID pneumonia, whereby 61 to 81% they require intensive care. So it follows a predictable time course over the days, where after around 8.5 days after the symptom onset, they will need intubation. So here's another chest X-ray. On the left side is an early stage X-ray. There's a very ill-defined consolidation in the lower lobes. But then if you look at the X-ray on right side, it's already late stage. You can see pan-lobar pattern of lung involvement, condition, and basically the lung architecture is already lost. Okay. So moving on to management, we essentially give the patient oxygen because most of them are hypoxic, anticoagulant because COVID illness makes you prone to all the DVT and all. Antiviral, we mainly give during a viremic phase that I mentioned earlier, and steroid, we need to suppress the body's immune response. Okay. So first I'll start.
Just go to previous slide. Dia bukan nak immunosuppress.
Ah.
Dia nak immunomodulate.
To modulate.
Immunomodulate, that's the keyword. Tu dia pun tulis. Dia bukan tulis immunosuppressive agent. Dia tulis immunomodulate. You want to modulate the immune response. You don't want to suppress. You want to modulate the immune response. Okay.
Okay. So for oxygen, in the clinical setting, like we basically see in the hospital, there are a lot of oxygen delivery equipment like your nasal prong, your face mask, high flow, venturi mask. So each of these devices came with their own FiO2 percent delivered. So I've put on the table over the right side because this is important because we need to calculate the Epf ratio. How you calculate is that you take the arterial PO2 on your ABG divide by the FiO2 delivered. So if a patient have a Epf ratio which less than 300, it indicates acute respiratory failure lah. If less than 300 is a mild ARDS, less than 200 moderate, and less than 100 is a severe ARDS. Okay, so this is an example for you to calculate the Epf ratio. Say if patient on 3 liter of nasal prong, we take room air as 21% of oxygen, which is 0.21 FiO2. Plus, if you give another additional liter of oxygen, means that's 0.04 FiO2. So, if a patient having arterial PO2 of 70, you divide by 0.21 plus 3 liter of 0.04 FiO2. So this is the result, like roughly how we calculate. Okay, so normally we see in the ED, most of the patient require an IV. I'll touch on a little bit on Cpap, BiPAP, and high-flow nasal cannula. Okay, so for Cpap, it's a continuous positive airway pressure. It delivers constant flow of oxygen at a prescribed pressure, which means that the pressure is constant during the patient's inspiration and expiration. They having this constant pressure to create the residual volume to prevent your alveoli collapse. And this thing usually recommends at a higher level than normal intrinsic pressure because type 1 respiratory failure that occurs in COVID patient is either due to collapse of your alveoli or there's widened gap between alveolus and blood vessels, which reduce your gaseous exchange. The peak setting is the one you set to prevent your alveolar collapse, which then can increase your lung volume and distance to reduce the distance between alveoli and blood vessels. Cpap, there are two forms you can see in the picture. Because this thing we have to give patient in a very sealed system, so we can either give it through a tight-fitting mask or a hood. And Cpap is less likely to be effective in patients who have poor tolerance to pressure and with productive cough because situation will require frequent removal of mask for suction. Okay, BiPAP. BiPAP, we give to patients with chronic obstructive respiratory disease, like say this patient have asthma, COPD, plus with COVID, we give BiPAP because it allows for high driving pressure coupled with low driving pressure. it resembles Cpap but provides additional support. If you give by PAP, it carries the risk that inappropriate setting may allow the patient to take in a huge tidal volume, which cause barotrauma. So we need to assess for pneumothorax prior to BiPAP. Okay, so there are two things in BiPAP. One is inspiratory pressure and another one is expiratory pressure. So we can calculate the pressure support with the expiratory minus the inspiratory. The recommend pressure difference would be at least 8 centimeter pressure. Okay. So next one, we move on to high flow nasal cannula. According to WHO guideline, they have support the use of high flow nasal cannula in certain patients, but still we have to close monitor this kind of patient for clinical deterioration, which will result in emergency intubation, and which subsequently will increase the risk of infection for healthcare workers. Sometimes we can use this cannula for patients with increased respi effort. But if you see patient with severe respi distress, severe CVS instability, unconscious, upper airway obstruction, basal skull fracture, epistaxis, impaired ability to clear secretion, basically some mechanical factors, then we wouldn't proceed with high flow nasal cannula lah. One thing to note that is high flow nasal cannula can dry out your lining of respi system. So we can use it with humidification, water chamber, and fluid bag. And to initiate the flow rate, we usually give 60 liters per minute oxygen to achieve the saturation, and subsequently we titrate accordingly. Okay. Okay, another important subtopic that we have to take note is management of asthma or COPD patients during our COVID time, because last time we used to nap all these patients, and during this pandemic we tend to avoid nap because we need to reduce the aerosol spread to reduce the risk of infection. So I've obtained this information from Malaysian Thoracic Society, where we can use MDI for asthma patient. First, we give them 2 puffs of bronchodilator, and if it's inadequate, we repeat the same dose every 2 minutes until satisfactory response, or maximum 6 to 10 puffs. If still not controlled, then we need to consider admission. If it's controlled, we ask the patient to use 2 puff bronchodilator every 20 minutes for 1 hour, and after discharge, we tell them to take another 2 puff bronchodilator every 4 to 6 hours for 2 to 3 days, and then follow their regular dose. And for patients who cannot use MDI, like kids or those with poor inhaler technique or severe dyspnea, we can give MDI with a spacer. In asthma patient, we need to give oral prednisolone for another 5 to 10 days in addition to this bronchodilator lah. Supplementary oxygen for severely breathless patients as well. Okay, so moving on to anticoagulant, we essentially give either prophylaxis dose or treatment dose to all the patient. So if the patient requires supplemental oxygen, we need to give prophylaxis dose. And if the patient is in ICU, or you see the inflammatory markers like D-dimers is basically increasing in trend, we need to give high prophylactic dose. And in those who are having VTE or suspect PE or have some clotting of vascular device, we can start them on full dose treatment dose. Okay, so the dose we need to see how much the patient weigh. If they are less than 50 kilo, I'm talking about the prophylaxis dose, less than 50 kilo, we give 20 gram, 51 to 90, give 40, 91 to 130 kilo, we give 60, and if they are 131 to 170, we give 40 mg BD. And if they are more than 170 kilo, we calculate lah 0.6 milligram per kilo per day. We can divide the dose in BD dose. If patient having renal impairment where the eGFR is less than 30 milliliter per minute, we should reduce the dose by half. Okay, and here's the table for treatment dose. It follows the weight as well, 50 to 150, we give 1 milligram per kilo BD. And then less than 50 is 40 milligram BD, more than 150 kilo, 0.7 milligram per kg BD. If eGFR less than 30, we reduce the dose to 1 milligram per kilo OD. So there are some cases where we need to increase to treatment dose in condition where the D-dimer is more than 1.5, the CRP ferritin or the inflammatory marker is increasing or worsening X-ray, or when you confirm that the patient is actually having PE or DVT. Okay. So, if patient having thrombocytopenia, we need to watch out because if you are giving an anticoagulant, it may cause a bleeding tendency. But if the patient is having platelet of more than 50 but no bleeding, you can go on with the recommended dose. If the platelet is 30 to 50, no bleeding dose, for prophylaxis, you should reduce to 50%. And treatment, you may consider reduce the dose lah. You need to weigh the risk and benefit. But if the platelet is less than 30, you need to straight away withhold. Okay. Antiviral for COVID. In our hospital, we didn't practice this, but I'll just go through the slides. Okay. Antiviral used in COVID-19 is favipiravir. Okay, it works by inhibit the RNA-dependent RNA polymerase to stop the replication. Usually, we give this medication to patients during the viremia phase, and it is contraindicated in pregnancy because it can have some teratogenic effect. So we ask the patient for contraceptive method for both men and women for 14 days after the end of treatment. Okay. Just a little side note on how we administer and the dosage for this medication. We load the patient with 1,800 milligram at 0 and 12 hours. We give 2 doses and maintain with 800 milligram BD for 4 days. We need to complete it for 5 days lah. Okay, so steroid therapy to modulate the inflammatory response in our body. So in ED, we essentially give patient IV DHsah if the inflammatory phase is already day 5 and above. In this kind of patient, we give 6 milligram OD for 5 to 10 days. But if patient came in with a high oxygen requirement or high CRP, ferritin and all, we can start them with 8 to 12 milligram in BD dose. 8 milligram for those with less than 100 kilo and 12 milligram for more than 100 kilo. And this table I think we usually practice in the ward lah. Like those who require nasal prong, we give DHSAH, and group B patients where they require face mask or they require nasal prong but doesn't improve with DHSAH, we will give them methylprednisolone. And group C patient is those with oxygen requirement, which is high flow mask and above. We will trial with pulse MTP and then slowly step down.
Okay, just be aware lah. This is ideal punya guideline. Tapi sometimes you have to be aware of local guideline jugalah. Even masa we have the outbreak recently kan, the guideline sometimes changes according to basically what we have lah. Kan recently we ran out of methylpred, dexamethasone stock is low and everything else lah. So sometimes yes, this is the ideal guideline, but also you need to be aware of local guidelines jugalah. Okay, local policy lah. Okay, carry on.
Okay, so because once you start the patient on IV steroid, we cannot discharge the patient with IV medication. We need to slowly step down to oral medication. So those who are on low dose DHSAH, we can step down to oral DHSAH to complete 5 to 10 days. And those who on high oxygen requirement and all, we can change to prednisolone and slowly wean down every 2 to 3 days. Okay, and watch out for relapse. And this is another table showing that the usual dosage for you to taper the dose over the weeks depends on patient's condition. Okay, so monitoring in hospital, Cat 1 patient, if they are asymptomatic but they are in your high risk group, we can take baseline blood and do a baseline X-ray with ECG and monitor. If they start to develop symptom with warning sign, then you repeat as necessary. Cat 2, symptomatic no pneumonia but high risk group, you still have to do all the baseline blood and X-ray. And if they have no warning sign, you repeat FBC CRP X-ray at day 9 or 10 of disease. If the CRP is more than 20, you repeat the next day. But then if you see the patient is clinically well, CRP static, you can discharge. Cat 3 is those with symptomatic pneumonia. This kind of patient, they require vital sign monitoring. And once they dissect, you have to attend immediately lah. Same as Cat 1 and Cat 2, you take all the baseline blood and X-ray. You can only discharge when they are clinically well and CRP static, and repeat all the tests as necessary. For Cat 4 and Cat 5, still you need to close monitor the patient, and you have to monitor all the inflammatory marker as more frequent as compared to Cat 1 to Cat 3. Ferritin biweekly and weekly based on the patient's condition, D-dimer when they are hypoxic, and repeat all the ABG as the patient dissect, because they are mostly on oxygen. And before discharge, you have to do a X-ray before they go home. Okay. So here's a summary for management of patient for category 1 to 5. So for Cat 1, Cat 2, if they are stable, no comorbids, we just observe. And Cat 2 with high risk, here we don't practice this lah. Can give antiviral. And for Cat 3 and above, basically for all patients, we need to give anticoagulant and steroids, especially if the onset of illness is more than 5 days and above. We need to start them on DEXA. Okay. Okay. So here's a table on how do we discharge patient for Cat 1 and Cat 1 to Cat 3. We can discharge the patient on day 10 of illness. Cat 1, Cat 2, you don't have to follow up post-COVID. But then Cat 3, the one with pneumonia, we need to TCA 2 weeks in the ID clinic. And Cat 4, Cat 5, we can only discharge after day 14 of illness, after they resolve symptom and able to bring down oxygen. So we refer RESPI and DCA ID to review. Okay. So basically, that's a rough idea on how we manage COVID patient.
Okay. Habis dah? Is that the end? Oh, okay.
Yeah.
Any questions to Chai? I think by this time you guys should be the expert in COVID management already lah. At least the emergency part lah. So from I think the criteria that I think you guys should be aware is which patient yang you need to start DEXA apa semua dekat ED lah. Because sometimes nowadays it's not as much, but before we got COVID patient who are stranded in ED for 3 or 4 days kan. So sometimes we need to start to initiate the DEXA, the Plexin and all the rest of it lah. Kan? Sebab because patient stays dekat us for a while. Cuma recently we've stopped seeing we've seeing less of severe COVID kan. Probably because of the vaccination program or probably because COVID itself is slowly going away lah. Hopefully. Okay. So any other questions? Kepada Chia Ying or to whoever, or any opinion ke? Kalau tak ada, kita proceed lah. Abdullah kan, tinggal Abdullah kan.
Ya, Abdullah.
Hopefully Abdullah will be a quick one lah sebab sikit je. Okay.